Okay, this is going to be Chapter 6, the Skeletal System, Part 2. My apologies. And this is going to be a general overview. This entire slide set is essentially going to be just pictures of bones. So what I would do is I would take a look at the actual figures in the book in this section, go over as many bones as you possibly can. Especially by sections. Know the difference between the axial skeleton versus the appendicular skeleton. I would also use the flashcards on G-Flash that are for this chapter. So obviously in figure 623 I would pretty much know, and I'm just going to mark these off, skull, clavicle, scapula, humerus, ribs. Know which ones are true ribs and which ones are false ribs. Whenever we get to the vertebra, I'm going to need you to know these individually. Radius and ulna. Pelvis, and we'll talk about the pelvis individually. Coxal bone, sacrum, coxal bone, coccyx. Carpal bones, metacarpal bones, and phalanges. Going to be in the hands. Femur, patella, tibia, fibula, tarsal bones, metatarsal bones, and phalanges. The little pieces on the ends are called phalanges in both the toes and the fingers. Carpals are hands, tarsals are toes. The axial skeleton is in yellow here, which is pretty much this area here. Some people say whenever they're doing assessments or they're being graded on assessments, seen secure gloves on, axial control of the head. And what that means is they've taken control of the axial skeleton or the head and C-spine. Please know all of these bones that are in here. There are 22 bones in the skull. We'll go through some of those that you may not need to know. Cranium, face, auditory oscles, hyoid bone, kind of important, sternum, ribs, the thoracic cage, the vertebra, and more specifically you need to know like which ones are C-spine, how many you have, thoracic, lumbar, sacral, and then coccyx. Appendicular skeleton, please go over these. You're going to need to know if they tell you where the trochanter is, or the patella, or the medial aspect of the fibula, or the medial aspect of the tibia, where that actually is. So please go over these bones. Adult skull, from the side view, parietal, frontal, need to know those. Occipital bone, which is the entire thing at the back. Temporal bone, zygomatic bone. The ethmoid bone, which is the green here. Kind of important whenever we're talking about not putting anything in somebody's nose that has a basilar skull fracture. Mandible and maxilla, know which ones those are. Zygomatic arch. Styloid process. Mastoid process. Those are little processes. This is where, back here, is where you'll get battle signs at if someone has a head injury. From the frontal shot, does everyone see this green? This is your ethmoid continued. And it is actually, more of it's in your sinus cavity than anything. Again, showing the green, which is the ethmoid bone. Foramen magnum, which is where your spinal column comes out of. Atlas and axis, we'll need to talk about those. Take a look over these. Nasal bone, mastoid, frontal, definitely, temporal, lacrimal, which is where your lacrimal ducts are, maxillary bone. Please take a look at over these and get them in your head. You should be able to differentiate what would be on the test by taking a look at the homework. Sectional anatomy. Now, everyone hopefully remembers the NG tube that's in that guy's head that I showed you whenever we did a CAT scan, and that's because he had a basilar skull. A basilar skull fracture is essentially where your brain is sitting on. It's in cerebral spinal fluid. It's in this area here. If there is a break or a Lefort fracture of the ethmoid area and we've lost continuity here, and we insert something into this area trying to get it in the stomach, it could take a straight shot into their head, which would not be good. So head injuries, facial fractures, please do not put anything in the person's nair or nose. We have the sinuses, which there's a lot of them in your head. Anybody that's ever had sinus problems, all these areas drain either down the back of the throat or out the front. Hyoid bone's generally fractured when someone hangs themselves, and it's a free-floating bone. It's a nice area to where we can attach ligaments and tendons to control our voice box or keep our upper glottic area or our trachea in place from the top. Skull of the newborn, and the important thing of this, the bones are the same, however most of them have fontanelles and things that are cartilaginous. Now ossification will occur at some point. Everybody will be a little bit different on this, but whenever their fontanelles close up, ossification has occurred, and the bone has grown and created squamous sutures, and I'll kind of show you on the adult skull here. These are where our fontanelles were whenever we were very young. Cervical vertebra, need to know C1 through 7, T1 through 12, L1 through 5, sacral and coccyx. Now, we have weak points in the spinal column. The weak points are essentially where another structure is holding on, and now we have free-floating vertebra. An example of this is going to be C1, C2. The skull is anchoring C1, so we might have more fractures in this location. T1, C7, T12, L1, and then L5, sacral S1. Now, why that's weaker is this area here has the rib cage and has other structures and muscles on it. This area here is kind of free floating, which is C2 through C7. Again, you have T1 anchored by the ribs, C7 free floating, T12 anchored by the ribs, L1 free floating, sacral S1 anchored by the pelvis, and L5 free floating. So all of these areas can give us weak points, and if we have enough trauma, can actually give us a fracture in that location or dislocation, which would even be worse. These are irregular bones, and the reason that they're irregular bones is because they have holes in the middle of them. The bones are structured like any other thing. However, we will see the spinal column running down these various holes, where they're input or output throughout the body, and then running to various locations along nerve tracts. So the vertebra is kind of irregular. It has multiple parts and pieces running down the interior of it, and it's made to protect a very delicate structure, which is the spinal column. Atlas and the axis. This is C1 and C2. C1 is the atlas, and C2 is the axis. You have one ligament This is the dens or the odontoid process, and this is what kind of anchors it, and this ligament holds it in place. Now this top one here that we're drawing on is C1, and then this is C2. C1. Now what we can get is, if enough trauma occurs, the breaking of that ligament, and then this thing can break off that odontoid process and slide forward. That would cause major damage. The higher you get on the spinal column, the more autonomic function that actually occurs. This would be high enough to where it would invade or give problems to your cranial nerves. Sacrum or coccyx. This is kind of encased in the pelvis. This here is free floating. This is what most people refer to as your tailbone. This is the anterior surface, which your pelvis and your bladder and all that kind of stuff would be in this location. Bladder towards the front, intestines toward the back. Thoracic cage or rib cage, you have true ribs and false ribs. Be aware of those. The flat area here is called the mandible. You have the body, and then you have a process that we sometimes break in CPR, which is called the xiphoid process. It's also a landmark for good chest compressions. Clavicle, this thing gets broken sometimes. It hides your first intercostal space on your rib cage. Clavicle kind of anchors your shoulder muscles and shoulder girdle back to where it should be. Without your clavicle, your shoulder will generally rotate forward, as if you broke one or something like that. Scapula, good area to attach all the muscular structures in the back that hold our shoulder and allow our shoulder to function. Acromenon, scapular spine. This is the scapula from the side. This is the posterior, and then this would be the anterior view. This would be, you have ribs in this area, looking at it from the front. In this area here, this is what it would look like on the back. So the scapula, be aware of the areas and locations on it. Humerus, which is in the arm. I would know where this is. Tubercle, the shaft, the diaphysis, radial fossa. This is where your ulna and radial is going to attach. This area here, considered the trochlea. Please be aware of those areas and look over this when you're doing your homework. Radial ulna radius is on the thumb side, if you'll always remember that. It's where we check a pulse. We also have head of the ulna and head of the radius. Be sure you can identify them. Tuberosity is a flat portion, so in this area here we have an ulnar tuberosity. Radial notch, trochlear notch, which attaches to the end of the distal end of the humerus. I would know these are phalanges. I would know the metacarpals, and what I mean by that is just know where the metacarpals are. And know that the radius, which one would be the radius, and the radius is always going to be on the thumb side. Pelvis, this is what I was talking about earlier with the sacrum, located in the pelvis area. Ilium, I would know that. Coccyx, ischium, pubis. This right here is the symphysis pubis, a little cartilage in the middle. So be aware of these on the coxal bone: ilium, ischium, and pubis. Differences between the pelvic anatomy between a male and female, and the differences are that the pelvis in the female is generally wider, and that would be for the birthing in a child. Greater angle allows for the actual child to come down through the birth canal. The femur, greater trochanter, I would know that. This would be the head of the femur, or actually in the hip bone. Lesser trochanter, shaft or diaphysis of the femur. Lateral condyle, medial condyle. Know which sides are lateral and which sides are medial. Tibia, fibula. We actually place our IO needles in the tibial tuberosity, and this is going to be on the medial side of the bone. So this is going to be in the inside of the leg. Always get your location correctly. Some people I've seen make mistakes and they'll put it in on the lateral side. The best shot at it is actually going to be on the medial side. So slow it down whenever you do skills like that, and just be sure it's in the appropriate location. Bones of the foot, I would look through the metatarsals, cuneiform bones, calcaneus. Easier probably to see from the side. This is figure 645 in the book. Structures in the synovial joints. Synovial joints provide fluid and essentially they provide cushion for joints. This one here, this would be the patella. This is the knee. Meniscus. If someone tears a meniscus, this is this area here. It has ligaments around it too, where you're talking about the anterior or the posterior cruciate ligament. I would know the difference between abduction and adduction. Adduction is towards the body, abduction is away from the body. So be sure to know that. Know that flexion and extension. Flexion would be closer towards the body. Extension is farther away from the body. And if you think about the core being the body, if I extended my leg out all the way, that would be straightening it out. Rotational movement, look over that. Lateral being towards the outside, medial being towards the core. Pronation versus supination. If you're prone, you're on your stomach essentially, or your under part down. That would include your hands. Supination would be back down or supine. Special movements, inversion and eversion. Please be sure inversion would be towards the center of the body. Eversion would be away from. If you're trying to document. Dorsal flexion versus plantar flexion. Be sure and look at those. Dorsal is going to be toes up, plantar, toes down. Elevation, depression, retraction, protraction, opposition, which is the movement of these two fingers together. You had one here and you had one here, and now you brought them together. Various classifications of joints. Please look over these. You have gliding joints, which is the clavicle. You have hinge joints. You're probably going to see what are examples as far as test questions go. You have hinge joints, which would be the elbow. You have pivot joints, which is atlas axis, or C1, C2. You have ellipsoidal joint, which would be in your hand, in your metacarpals, and then you have saddle joints, which would occur in the actual phalanges, and then you have ball and socket joints, which would occur in the humerus or the shoulder. Intervertebral articulations, spinal column, remember that hole that I said that was in those irregular bones? You have ligaments that attach all of these things together, and you have discs that are in between the two. Now the problem with this is if we strain this or put a severe angle on it, it can squeeze and rupture this disc, which would protrude it into the spinal column. These intervertebral discs, people rupture the discs all the time from high stress on their spinal column. Shoulder joint, there are tons and tons of ligaments in here. Anybody that's ever had a shoulder injury can tell you that this is a joint that you definitely want to take care of. Clavicles are locked down here to your actual shoulder girdle and acromenon. You have a bursa that's in here. You have a joint capsule. There's some synovial fluid in there as well. The articulating cartilages can get damaged in the shoulder area, so take good care of your shoulder joints. Please go over this. This is figure 6.52 in your book. Elbow joint, same way. You have a lot of surface area. There's a lot of friction that can occur in this. If you get arthritis or inflammation of this joint, this one will definitely let you know that it's in pain. Synovial membrane, we have joint capsule that's in it. This is the humeral head right here, and this is the radius. There are a lot of ligaments and tendons attaching this elbow together. You have bursal sac towards the rear in your elbow, or what you would think of as your elbow. There are nerves down there for anybody that's ever hit their funny bone. Lots and lots of moving parts in your elbow. Hip joint. We have joint capsule. People dislocate these. That's because the ligaments that hold this in place become weak or old and don't work quite as well as they normally did, or they've done it before and they've caused damage to it and kind of stretched it out. You can move this in two locations. You can have either a posterior or an anterior dislocation, and it essentially just comes through the ligamental connective tissue. Knee joint, this is the posterior, this is the anterior cruciate ligament, and it's pretty much, if anybody that's ever broken one of these, that's pretty much where they're located. Anterior is going to be on the front side, posterior is going to be on the back side. We have the patella. Some of the muscles from the femur are actually attaching to this to keep it in a good location. We have a big, large synovial fluid membrane that's in there in the joint capsule, and then we have a meniscus that allows a little bit of padding to occur in this area. So if you've torn your meniscus, this is what gets actually torn. If you've ripped apart your anterior or posterior ACL or PCL, it's these areas here that get torn, and this loses continuity of the joint. This is figure 6.56, and remember I said that this is a good idea to go over this. This is what interacts, or how the skeletal system interacts with other systems in the body. So this is how it's going to interact with the integument, muscle, nervous, and so on. Please look over these so that you get kind of the bigger picture as we're going through these. Now we're going to go through these in sections. So we just went over the integument system in 5. The skeletal system is kind of right here. The next one we're going to go over is the muscular system. After that, the nervous, endocrine, cardiovascular, lymphatic, respiratory, immune system will also be in lymphatics, digestive, urinary, and then reproductive. So we're going to go through them by the numbers, essentially. If you have any questions, this is the end of part 2. Please give me a call. My name is Roy Smith, 405-219-7613, or you can email me at smithr@imsa.net.